Hi, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for the Foundation, and I'm joined today by Dr. Aaron Boster, who will answer as many of your questions as he can for the next 60 minutes. Now I'm delighted to introduce him. Dr. Boster is a board-certified neurologist specializing in multiple sclerosis and related central nervous system inflammatory disorders. He lectures to MS patients and provides worldwide with a mission to educate, energize, and empower. I love saying that. People impacted by multiple sclerosis. We're so pleased to have him today. And just before we start taking questions, Dr. Boster, let me at least explain to people what they're going to be doing. So I'm going to suggest to everybody, we're trying something a bit different right now. Instead of having questions in the Q&A and in the chat area, we're going to leave the chat area for the questions that are coming in from Facebook viewers for those participants. And so I would ask everybody to please put your questions in the Q&A area. If you can do all of that by anonymously also. And if you want to do this on your phone, you can just hit *9 and we can take your question from there. So let's see, let's start. Let's see what we have. We have quite a few people. We don't have any questions yet, so oops, we have two. Vince wants to know, how often do you recommend a spinal tap to test for O-bands?
So first of all, I'm super excited to be here and thank you for having me back. And thank you everyone who's jumped online to join us today. So when you're working someone up to determine whether they might have multiple sclerosis, there's 5 elements to the diagnosis. One is their clinical story, and we call that the medical history because it sounds highfalutin. And we're really listening for a history of relapses or progression. The second is the neurological examination. So, that's when the neurologist runs you through what I call the MS Olympics. And there we're really looking to see if there's exam findings which buttress the story. The third thing is the MRI. And MRIs have revolutionized the way we diagnose MS. They allow us to do it much faster. And if the story, the exam, and the MRI gives us a firm diagnosis, there really isn't a huge reason to do a lumbar puncture. However, sometimes it's not so crisp and clear. And you may have an atypical story, you may not have things on exam, or the MRIs might not meet the entire criteria, in which case getting a lumbar puncture can be very, very helpful. And so I would submit to you, out of 10 patients that I see that I'm working up for MS, I'm probably getting a lumbar puncture in one of them. And depending on which part of the world the question comes from, for example, in Europe, they do it almost ubiquitously. But that's my answer for my practice.
Thank you. We have a question that came in. Let's see, this is from Michelle, and she said, Dr. Boster, can kmta cause burning in arms or night sweats with loading doses?
So kmta is one of the B cell depleting medicines. Okay, so it's called an anti-CD20, which is doctor talk for it suppresses the B cells. And kmta is one of several. So there's Rituxan, Ocrevus, Briumvi, and kmta. They're all in the same class. And kmta is the only one which is a self-injection. So the other ones are infused in the vein. Kmta comes in a prefab, like a pen, and you give yourself a shot. And some patients, I would say a minority of patients during the first and possibly the second injection can feel kind of flu-like. So I have heard of night sweats, I have heard of ouchie yaya, but it typically doesn't happen. And when it happens, I've never seen it past the first 2 loading doses. I recommend that when patients, if you experience that you take an aspirin or a Tylenol or ibuprofen, the same way that you would treat like flu-like symptoms. And I think it's highly likely that the next day that's all going to dissipate.
Thank you. Nancy would like to know, let's see. I was only diagnosed with MS in May. I'm 63, and the doctor's info and positive has been invaluable. Okay, that was just a mention rather than a question. I recently heard that DMTs do not help prevent lesions on the spinal cord. Is that true?
No.
Okay, thank you. And I am 43 years old. I'm a male with MS diagnosed by a neurologist. Have you had patients with an unusually high white blood cell count in their spinal fluid? 92. I know it is unusual in MS, but that is my situation. Everything else pointed to MS, including MRIs, um, oligoclonal bands, etc.
All clonal bands. So that is high. So when you're collecting spinal fluid for workup for possible MS, the standard thing that we look at, as the gentleman mentioned, are oligoclonal bands or OCBs. And another thing we look at is the IgG index, which are really telling you the same thing. It's looking at the number of antibodies in the spinal fluid as compared to the bloodstream. And that's the most important. Secondarily, we're looking at the white blood cells, and normally you should have 0 to maybe 3 white blood cells in the spinal fluid. But it's not uncommon when you make an MS diagnosis that it can be much higher. I was taught that it shouldn't ever be over 50. And so I was taught if it's over 50, I better do a darn good job of making sure I cross all the other things off the list. So is it possible? I would say it's possible, but I would want to make doubly sure that we're ruling out neurosarcoidosis with a chest CT. I would want to make sure that we sent off antibody tests for MOG. I would want to make sure that we sent off antibody tests for NMO. I would also want to make sure that we're looking for paraneoplastic syndromes, things that can mimic MS. So I wouldn't say that therefore you don't have it, because it certainly sounds, based on what you're describing, that you probably do. But I would really want to make sure that I crossed off all the other things on the differential diagnosis.
Thank you. In your opinion, which DMT that does not continuously suppress the immune system is the best?
Limtrada. So alemtuzumab or Limtrada is a reboot, and it's a very, very robust therapy. It's discontinuous because you give 5 days, and then a year later you give 3 days, and then you don't give it anymore. So it meets the criteria as mentioned because it doesn't chronically suppress the immune response. It's so effective, really, that in my mind, it can only really be compared to a stem cell transplant. But it's also important to say that it's also probably the highest risk in complexity of all the different DMTs.
Interesting. Have you noticed sugar causing symptoms to be worse?
100% yes. Yes, 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 yes. In fact, if you're listening to
Emphatically.
this and you don't believe me, I'll give you a challenge to remove sugar from your diet for a month, and you will be blown away by how much your symptoms decrease. I've seen it time and time again.
Wow. After what age would you stop taking DMTs?
Death. I never ever treat past death. So I refuse, because none of the drugs have been studied after death. And so I've never once done that in my entire career.
Am I considered immunocompromised until lymphocytes come back up, or is it longer after completing Mavenclad?
When your lymphocytes are within a normal range, you're no longer immunosuppressed.
How safe are ports currently to Sabri JVC positive, very difficult stick, change DMT, or port thinking Mavenclad? Really scared.
So some of the MS medicines are self-injection shots, like we mentioned Kymta earlier. And some are pills, like Mavenclad, like mentioned in the question. But a lot of the higher efficacy drugs are infused in a vein. And for various reasons, sometimes people have trouble with venous access, which is doctor talk for it's hard to get a vein started. And when you have Tysabri, you're getting 12 to 13 infusions a year, which means 12 to 13 times we have to gain access to your veins. And so there can be situations where that can become really challenging. A port is a plasticky kind of device, which is typically implanted in your chest, like right here, under the skin. And a port requires it's a procedure, typically done either by a surgeon or by an interventional radiologist, and it lives under your skin. Ports are not without risk. So when you place a port, there's a couple risks, and I don't mean to sound scary, but they could drop your lung, God forbid. You can get a blood clot, or you can introduce infection. And you have really smart people doing it. And then having a port requires you to maintain it. And oftentimes, once a month, you have to have it flushed, and there is a risk of infection. So it's not a completely like no-brainer. I try to avoid ports when possible because I don't want to increase the risk for my patient. But I do have some patients where that's simply not an option, and so we place a port. And so I really think it depends on how hard it is to get the IV. And you have to do this risk-benefit analysis as to whether or not you do it or not.
Thank you. Can you please discuss your opinion on Pipe 307 and other remyelination drugs currently in clinical studies?
So Pipe 307 is a medicine, or it's a potential medicine, which was successfully tested in mice. And so it hasn't been fully tested in humans yet. So if you are a mouse with multiple sclerosis, you 100% want to be on Pipe 307. All right. So any mice with MS that are listening, you want to do that right away. If you are a human with MS listening, we don't know yet. And it's very exciting, but it's not prime time. It's very early. I have a friend, a work friend, named Brandon Bieber. Dr. Bieber is an MS doctor, and he, like I, has a really great YouTube channel. And he made a wonderful video on Pipe 307. So if you want to learn more about it, then I would check out Brandon's video.
Okay, great. Does the number of bands in the oligoclonal
The
bands,
oligoclonal bands.
thank you, indicate anything? I am 37, just diagnosed last week and had 19 bands in the CSF.
So yes, it represents kind of like two things. So when you're trying to diagnose someone with MS, if they have several bands, and it's typically either 2 or 4, depending on the lab. So let's just say 4, because that's the most common. If you have 4 bands in the spinal fluid, which are not seen in the serum, because you're doing a comparison, then that supports a diagnosis of MS. It doesn't prove MS, but it supports a diagnosis. And with the 2017 revised McDonald criteria, that's the criteria that we use to diagnose MS, it actually helps contribute to clarifying the diagnosis. And so from a diagnostic standpoint, it can be very valuable. There's also a question about whether or not the number of bands has a relevance, and I believe that it does. More bands is prognostically not good. And so I would view 19 bands as an independent risk factor for we really need to be on point with your disease because that might suggest a worse prognosis potentially.
Thank you. If you have a lot of MS-like symptoms, but your latest MRI didn't show any lesions, are there any tests you recommend doing for other similar conditions or autoimmune diseases that are very similar to MS?
Yes, and answering that question could be like a 2-hour master's class because it's a really, really big question. It's essentially saying, what is the other things on the list, right? So I tell people if I started to write at the top of the wall here and I wrote all the options, I would get to the bottom of the wall and I wouldn't be done yet. That stated, there's categories. So when I'm working someone up for possible MS, I'm going to send off a battery of laboratories to look for infections I don't think they have, like syphilis and HIV and tuberculosis and stuff like that. And I'm going to send off some metabolic labs like vitamin B12 and thyroid and things like that. And I'm going to set off labs to look for connective tissue diseases that can mimic MS, like lupus and Sjogren's and stuff like that. I'm also going to make sure that I've imaged the brain, cervical spinal cord, and thoracic cord. And sometimes I need to send off a chest, abdomen, and pelvis CT to look for, God forbid, cancers and things like that. So there's a robust evaluation which is done to look for other mimics of MS.
Thank you. Okay, so this is Luann has asked this, she sent it in. What is your opinion of the medication Tysabri? I just started it 2 months ago. What kind of results should a person get from it? I was diagnosed 33 years ago with relapsing remitting and began using betaseron in 1994 until 2021, when I was told by my neurologist I had moved into the secondary progressive stage. She put me on Mayzent, but I don't feel like it helped me much, and I did decline some over the next 3 years. I had an MRI in August 2024 and active lesions were found. So she decided to stop the Mayzent and put me on the Tysabri.
That is an A-plus question. All right, so let me deconstruct the question. Tysabri is one of the most effective medicines that has been used to treat MS. It came out in 2004, and it's still, I would say, top 3 medicines. So if you think about technology from 2004, like you can't find a cell phone from 2004 because they're in museums, right? So the fact that Tysabri is still one of the top medicines is kind of a big deal. Tysabri works fast, but it doesn't work in 2 months. I would say you can start to see some clinical separation in 3 months, which is really fast by MS standards. So this is a really great story. Not the situation. I'm just saying as we think through the question. Mayzent is a Me Too drug. So Mayzent is a lot like Gilenya. It's in the same class as Gilenya. And the way that Mayzent was studied, they kind of tried to suggest that it treated secondary progressive MS, but I personally think that's BS. When I look at the data for Mayzent, the secondary progressive MS trial they did, there was a clear dose effect curve. So the younger the patient was and the more inflammation they had, the better they did. And so I really call shenanigans as far as saying that this is a clear medicine to treat secondary progressive MS. I'm not saying that it can't treat it. I just don't think that's why the trial was positive. Now, Tysabri does not have an indication for secondary progressive MS. There was one trial called the Ascend trial, and the Ascend trial looked at using Tysabri in SPMS, and it said it failed. But when they went back and they did what's called a post hoc analysis, it absolutely slowed down arm function, getting worse. And there's a really great series of editorials that have been written about this. Bottom line is, I think that it can treat secondary progressive MS. So the short and the long of it is I think Tysabri remains amongst one of the most effective MS medicines. I also want to point out that here's a story of a person who's had MS for a very long time. And they had an MRI, 30 some years in their disease, and they had enhancing lesions. They had active lesions. So don't be ageist. Don't say, oh, since you're such an age, we don't need to treat you anymore. Here's a vibrant person who is trying to live their best life, and they had an MRI that was active on a medium efficacy drug. And so it just brings out the point that we need to treat you independent of your birthday.
Thank you. Let's see. If a patient develops a worsening major depression as a result of MS lesions, is it most likely the result of a new lesion in a different location or the deepening or widening of the lesion that caused the initial depressive episode?
So there are parts of the brain which, if affected, can increase risk of depression. But I would submit to you that the vast majority of the time, that's not the underlying cause of depression in MS. It's not like, here's the depression spot. The general population experiences a rate of depression which is supposed to be about 1 in 4. I think it's much higher than that, but that's the data. And in MS, it's literally twice the general population. And so I treat depression very, very commonly in my practice. And I think there are 2 reasons why people impacted by MS can get depressed. I think not just the lesion itself, but having an inflammatory milieu in the brain is a setup for depression by itself. And when you look at medicines to treat MS that decrease inflammation, disease-modifying therapies, they always help mood. The second thing is it sucks to have MS. And there's an unknown So a lot of patients tell me they wake up in the morning and they kind of do a check, like, can I see out of this eye? Can I see out of this eye? Does this hand move? Does this hand move? And they don't know what's coming down the line. And I think both of these things create a setup for depression. But here's the important part. It is treatable. You can treat depression. And there are really effective treatments for depression. So taking a disease-modifying therapy treats depression. Exercising treats depression. Cleaning up your diet and avoiding ultra-processed foods and sugar treats depression. Removing medicines which can worsen depression treats depression. Treating fatigue treats depression. Antidepressants treat depression. Group therapy treats depression.
Mhm.
Talk therapy treats depression. So my point is, just because you happen to have MS and you're experiencing depression, don't accept that laying down. Treat it, because we can beat that.
Great answer. What's your opinion on taking 10 milligrams of baclofen a couple times a day for spasticity for someone over 65? Is it likely I will never come off of it? What are the worst side effects?
So let's talk about what is spasticity. So spasticity is a situation where opposing muscles are arguing. So I'm going to use my massive arm here. Okay, so when I want to bring my soda water to my mouth, okay, my massive bicep has to contract. It has to get shorter to bring my arm in. And my gigantic tricep has to relax, all right, because the tricep's goal is to put the arm out. And I don't say to my tricep, let go. I just say water, and my spinal cord and brain turn the tricep off. When there's been damage to the central nervous system, brain or spinal cord from any cause, including MS, then sometimes when the bicep needs to contract, the tricep doesn't get the email. It didn't receive the memo. It doesn't know it's supposed to relax. Then you have a situation where the bicep's trying to come in and the triceps saying, no, 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 I'm going to go out. And you have a tug of war against your own arm. And this could be your arm, it could be your leg. And that manifests in three ways: spasms, like a bouncing, a cramp, like a Charlie horse, where it cramps up and hurts really bad, or a stiff arm or leg. That's spasticity. And upwards of 70%, 70% of people with MS have spasticity. Now, spasticity is worsened whenever you have an infection. It's worsened whenever you're still, like sleeping. So waking up from sleep or getting up from being seated for a couple hours is really rough on my patients. And temperature dropping, the ambient temperature, like winter in Ohio, where it's kind of cold out today, increases spasticity. So there's lots of ways of treating spasticity. Chief amongst them is stretching and movement, like physical therapy. But sometimes we have to use medicines because that's not enough. Now, the neurotransmitter, which is not behaving itself in the spinal cord, is called GABA, G-A-B-A. That's the stop neurotransmitter. Baclofen is exogenous GABA. That's a doctor word for they made a pill that looks just like GABA. So you're kind of swallowing an analog of the neurotransmitter that you don't have. And so I use a lot of baclofen in my practice. I use oral baclofen, and I even have intrathecal baclofen pumps that I put in some patients. One time a patient jokingly called me Dr. Baclofen. Baclofen has side effects like all medicines, and most of them are groggy, dizzy, sleepy. So whether you're 65 or 35 or 25 or 75, I think baclofen is an option, but we always have to weigh the risk benefit. My secret sauce for starting baclofen is to start super, super slow. So I've seen some neurologists, they hand you a prescription of 10 3 times a day. I don't start that way. I start with 5 before bed for a week, then 5 twice a day for a week, then 5 3 times a day for a week. I'm slowly building up the tolerance. And a lot of times doing that, I can have good success. So that was a great question. Thank you for asking.
Thanks. My Tysabri infusion buddies take a 2-month infusion holiday once per year. They are JCV but positive. I've not heard of this from you. What's your opinion on
I
this?
think that's horrible.
Okay, thank you. Let's see. Can you in your opinion, which DMT that does not continuously suppress the immune system is the best, has the highest efficacy?
We already did that one earlier, and the answer is Limtrada alemtuzumab. Yes.
Okay, thank you. My hemoglobin keeps being very low. I have been on
Iron.
Fiosol, but level never went up. Do you think it's caused by Tysabri or any DMTs?
No.
Okay.
Sometimes nature's too generous.
If the DMT ocrevus stops lesion activity progression, can you regain walking with continued PT?
So first of all, I wonder if you're my cousin because our last names are both Boster. I'm joking. I don't think I have a cousin named Teresa, but hello. So so I think it's not fair to have an expectation that you're going to regain a function when you start any DMT. The likelihood that someone on Ocrevus has a sustained improvement is about 20%, which is gigantic. So about 1 in 5 patients on Ocrevus will notice an improvement in their function. But I don't think it's fair to enter into the drug demanding that. I think that Ocrevus, amongst other highly effective drugs, we can demand not getting worse, right? We can demand no attacks. We can demand no new spots on MRI. I think we can hope for improvement. But I love this question because physical therapy, exercise, is an underappreciated disease-modifying therapy. It slows down your MS. And we don't want to allow your body to become deconditioned. So I am delighted that you're working with physical therapy. And I think having a goal of wanting to walk again is a glorious goal, but I think we have to also be very, very honest with ourselves. So maybe we're not going to be able to do that, but maybe we're going to be much better at transferring from a wheelchair to the bed. Maybe we're going to be able to stand and pivot. I mean, those are not small things. And so I want you to keep on keeping on with physical therapy. And it's nice to see you, cuz.
Okay, I'm sorry, you had frozen for a second, so I didn't know you stopped.
Oh, sorry.
Let's see. Uh, I have I have had I have had MS since 1995, and I was wondering if there was any other medication for the spasticity. I'm now 63 and was wondering if there were any other medications that might be helpful. They're really bad at night and early morning.
So the caveat, Bill, is I can't diagnose you or treat you on the interwebs, and you have to talk to your doctor. And I'm not giving you medical advice. I'm giving you medical education. And here's the medical education. Magnesium treats spasticity. So like there's all kinds of different like flavors of magnesium, like magnesium oxide and citrate and gluconate and theanine, but those are all magnesium products. And between 250 to 400 milligrams once or twice a day can treat spasticity. CBD treats spasticity. THC treats spasticity. Baclofen, as we mentioned earlier, treats spasticity. So does Xanaflex, that's tizanidine. Botulinum toxin, Botox, or Dysport. These are injections which treat focal spasticity. So there's a host of things that we can use to treat spasticity.
Thank you. Sue said that she's never had any success with any DMTs. Is there anything new on the myelin repair? She's 59 years old, female. She's had it for 17 years.
So the research is still in the world of research, and we don't have anything that's prime time yet. I'm excited about clemastine. I'm excited about metformin. But it's still a research thing. And I assure you that internationally, there's tremendous efforts being pushed towards remyelination and neuroprotection. That is top on our list right now.
Thank you. Carmen from Facebook is saying that she has SPMS and also a rare disease, arachnoiditis.
Arachnoiditis, yep.
Yep, both are very similar, she says. Do you think they trigger each other? She's not on any medications because 3 out of the 4 treatments that she tried, her body could not tolerate them. Could it be that the disease is intensified by the MS treatments?
There's not enough information for me to be able to provide an adequate answer. Arachnoiditis is not super rare. It's an inflammation of the coverings of the brain. And I would submit to you simply that there's 28 different FDA-approved therapies. You mentioned 4, so you haven't tried very many. And it's my hope that working closely with your neurologist, you can find one that'll help your MS.
Thank you. Is there any correlation between my MS and my newly found
Hypogammaglobulinemia.
Thank you. They're 68 years old.
That is a great Scrabble word. So don't take it off the screen. If you look at hypogammaglobulinemia, emia means blood. Okay, gamma globulin means antibody. Gamma globulin means the IgG antibody. Hypo means low. So that's a doctor word for you have low antibodies in your blood. That's what that means. And hypogammaglobulinemia increases the risk of infection because you don't have all your antibodies floating around. Now, multiple sclerosis by itself does not cause hypogammaglobulinemia, but some of the medicines do. So, for example, some of the B cell depleting medicines like rituximab, Briumvi, Ocrevus, kmta, they can cause hypogammaglobulinemia. And so one of the things that I think is a best practice when you're treating someone with MS using those kind of medicines is you check the IgG level twice a year. If that level is below 600, that makes me pay attention and become concerned. And if it goes too low, we can stop the B cell depleter or give it less often, or we can add a medicine called IVIG. So IG, immunoglobulin, which treats the hypogammaglobulinemia. IVIG is you give it intravenously. So it's a really interesting question.
Thank you. What is the goal from taking Tysabri? This person just had their second dose. Is it to keep things stable and hope the physical symptoms of MS don't get worse?
So all of the disease-modifying therapies are like birth control pills against future events. So if you have 3 children and then you start birth control, you still have 3 children. They don't go away because you started birth control. And my joke is if you want to know why you're on birth control, go hang out with your 3 kids. And I'm just teasing, your children are wonderful. I'm not trying to suggest otherwise. But in the same fashion, if God forbid MS has made it so that you have trouble seeing out of your left eye, okay? You don't take a disease-modifying therapy to give you your vision back. You take a disease-modifying therapy to protect the fellow eye. You want to preserve the reserve. You want to protect the nervous system. And so the goal of any of the disease-modifying therapies, first and foremost, is no attacks, no new spots on MRI, no enhancing spots on MRI, no accelerated brain volume loss, and to slow, if not stop, worsening of disability. Now, that doesn't mean that you don't have symptoms, because you probably do. And so in addition to the disease-modifying therapy, in addition to that, we treat symptoms. And so I joke that I have a pill for every ill. And I'm going to use an off-color example, all right? So I'm going to say erectile function. So if that offends you, then I apologize. Some gentlemen with MS develop erectile dysfunction. And if it bothers them, I give them Viagra or Cialis. If it doesn't bother them, then I don't care. Because in this off-color example, treating erectile dysfunction has no bearing on slowing MS down, but it makes Friday awesome. So here's an example where, yes, we would want to slow MS down using a disease-modifying therapy, and then on a case-by-case basis, we want to treat symptoms that cause problems.
Thank you. Are antibodies always high in MS? My IgGs and my IgAs are low. In fact, my immunologist is talking IVIG infusions. A neurologist told me that I could not have MS because antibodies are high in MS.
So the neurologist is not accurate because you can have MS and have low antibodies. That's possible. And I have patients that have both those problems. And the IgA is not as relevant to me. So IgA is something which is related to allergies. And so if that's low or high, I don't really care too much. IgG, that's the memory antibody. And if that's low, as we were talking about earlier, that can increase the risk of infection. And so I think taking IVIG is a great way to protect against infection. And IVIG off-label has been shown in some small studies to slow MS. So I think you kind of get a twofer when you do that.
Thank you. And I can't pronounce this. Is pre
Pre-syncope,
a common MS
pre-syncope.
symptom?
So pre-syncope is doctor talk for I stood up too fast and I think I'm going to black out. So syncope is a doctor word for passing out. Pre-syncope is what happens right beforehand when the room goes dark and you have ringing in your ears and you get lightheaded. And no, it is not a common symptom of MS.
Thank you. Do you see any crossover of neurosymptoms between MS and celiac? I was diagnosed with MS 4 years ago, but now probable celiac as well. And it was mentioned that some neurosymptoms could be celiac related instead of MS symptoms.
So if you have one autoimmune disease, in this case, multiple sclerosis, we believe that you're probably at higher risk of having a second autoimmune disease, maybe celiac disease. Um, I have a couple patients that have celiac disease, and it's very, very rare to have neurological things with celiac. Like, I'm not saying it's impossible, but it's very, very, very uncommon. This is a situation where I'm reminded of what my mentor used to say. He used to say, Aaron, sometimes nature's too generous, and you can have two things going on instead of just one.
Thank you. What things should we be considering when thinking about changing B cell depleters? I'm currently on Ocrevus infusion 2 times a year.
So I think I'm going to broaden the question and just talk about when do you consider switching any drug, any disease-modifying therapy? I want to discuss switching a disease-modifying therapy under 5 conditions. If you have an attack on the therapy, that's not okay. If you have new lesions on the therapy, that's not okay. If your exam worsens while on the therapy, that's not okay. If you no longer tolerate the therapy, that's not okay. And if the therapy is no longer safe, that's not okay. So if one of those 5 things happens, it's an inflection point to have a conversation about should we make a switch.
Thank you. This is from Julie in Alaska. What is a better drug for SPMS for a person JVC positive, Ocrevus or Briumvi, or something other than that? She was diagnosed late, decided unfortunately during RRMS not to treat. Now was told too late, too old, and she's 69 and still working.
So first of all, I'm jealous that you live in Alaska because it's a really, really cool state. And I've only visited once and I want to go back. Second of all, it's not too late. We should not be ageist. So 69 is the new 39, sister. And I think as long as you have neurological features that you like seeing or smelling or hearing or having an orgasm or wiggling your hand or those are all neurological features. If you like any of those, we want to preserve them, right? Now, as far as what the treatment is, there's never been a comparison between Ocrevus and Briumvi. They're both B-cell depleters, and they're both considered high-efficacy drugs. So every neurologist has a bias or an opinion, but I think that those medicines are probably overall more similar than dissimilar. And I think that they're very good medicines, and so I would feel comfortable with having you on one of them.
Thank you. What is a better drug for SPMS for a person JVC positive?
Oh,
Ocrevus?
that's the same question. Yep.
Oh, I'm going back and forth, back and forth. Sorry
No,
about that.
no worries at all. It's you're
Ooh,
juggling.
I am juggling, trust me. I can confirm, Tiffany wants all of us to know that removing sugar as much as possible from your diet, just like you said, helps reduce intensity, severity of MS symptoms. Thank
Amen, my sister from another mister.
you. How much vitamin D should I take daily? And my level is at 43. Is that too low?
So again, anonymous, I can't diagnose you or treat you, and I'm not giving you medical advice, blah, 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 blah. So generally we want the level, and the level refers to a blood test called the vitamin D25OH level. That's a blood test to be above 50, but below 100. So that's the goal. Now, how do you get vitamin D? Well, you can go out shirtless in full sun for 15 minutes and you'll absorb 5,000 international units of D3. But if you live in Alaska, you're going to get frostbite on your personal parts. And if you live in Ohio, your neighbors might call the cops. Another option is to eat fatty fish like salmon or eat egg yolks, but the amount that you would need to eat is kind of colossal. Like you might have to eat the entire salmon every day, which is kind of probably not realistic. So I have my patients take a vitamin D3 supplement. Now, the answer to the question is based on how it moves the level. So it's very likely taking 4 or 5,000 international units a day would make that 43 go up. But again, we have to talk to your doctor and make sure that it's not too much and check levels, et cetera, et cetera.
Thank you. Should an MS patient get the flu shot?
Yes, 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 yes.
And yes, thank you. Is Mavenclad similar to Limtrada, but with less risk?
No. The things that's similar about Mavenclad and Limtrada are the fact that they are discontinuous therapies. So most therapies you take all the time. So I have high cholesterol, thanks mom and dad, and I take a cholesterol pill once a day, right? I do it every day. Why? Because if I don't take my cholesterol pill every day, my cholesterol goes up and I can have an increased risk of stroke or heart attack, which I don't want to have. So that's a continuous medicine. Most medicines are continuous. Most MS medicines are continuous. Shot once a day, shot 3 times a week, 2 pills a day, infusion once a month, infusion every 6 months. Those are all continuous. Mavenclad and Limtrada are discontinuous. You take them for a set period of time and then you don't take them again. Because mechanistically, what they're trying to do is they're trying to reboot part of the immune system, right? Mavenclad really mostly affects the B cells. It has a very small effect on the T cells, but it's really small. It's largely a B cell medicine. Limtrada affects both the adult B and the T cells. And so I do not think of Mavenclad as Limtrada light. They're different drugs with different side effect profiles.
Thank you. Marietta says that she has choroidal nevus, which is a mole on her retina. Can she ever use Mavenclad? She'd like to because Medicare is approaching.
So I don't think that's a contraindication. But
Okay.
of course, you're going to check with your doctor. But I
Yeah.
don't think that would stop me from using it.
Okay. What about short-term memory loss? I understand there is no cure, but what is the best way to help prevent episodes of memory loss? Sorry, if they're not asking it the right way.
So cog fog is very common in MS, right? Cog fog is where you're not as sharp on the uptake. And the memory and cognitive problems that we see with MS are not like Alzheimer's dementia. All right. So you're not going to like not know who you are or where you are or remember family. That's not going to happen. The kind of problems that we have with MS cognition are what we call in neurology executive function. So that's like keeping a list in your head or juggling multiple cognitive tasks at one time or working under time pressure, things like that. And so a lot of it boils down to difficulties with attention, like locking on to a task. If you can't lock on to the task, you can't remember it. And that will manifest as poor short-term memory. It's not actually a memory problem, it's an attention problem. And there are a host of things that you can do to treat that. So at the risk of sounding a selfless plug, on my YouTube channel, I have an entire playlist on cognition and MS with 20, 30 some videos where we talk about that extensively. But there are a lot of things that you can do. And I'll just name 5 just for the sake of our discussion. Making sure that you're getting proper restorative sleep is key, all right? Because if you're getting just a couple hours and waking up to pee and with spasms, you're interrupting your sleep hygiene, you're cutting your legs off before you start your day. Again, removing ultra-processed foods and sugar is really, really helpful. Treating depression is very, very helpful because if you are depressed, then it makes your cognition worse, period. That's called pseudodementia. It's very, very well understood. Exercising as part of your lifestyle improves cognition in MS. And lastly, there are symptomatic medicines, prescription medicines, which are stimulants that trick your brain into be more awake so you attend better. And so my point here is don't take that laying down. There's lots of stuff we can do to treat that.
Thank you. I have MS and RA. How do you feel about me starting Arava?
Arava. Yeah, I love that. So in the setting of multiple sclerosis, there's a drug which is FDA approved for multiple sclerosis called a bajio. And the generic name is teriflunomide. I didn't make up these words. There's a drug approved for RA called Arava, and the generic name is leflunomide. Now, when you take a pill of Arava and you swallow it, the first metabolite is a bajio, right? And Arava is generic and cheap as dirt, like $8 a month sometimes. And so I don't prescribe a bajio. I prescribe Arava because it's really, really easy to get. Now, there's another therapy which also treats both, and that's rituximab. And so I oftentimes will use either Arava or bajio for that matter, or rituximab or Ocrevus when I'm treating someone that has both those things.
Thank you. Good evening. I was diagnosed with MS, and during a lumbar puncture with IIH, my insurance keeps denying Ocrevus, so I haven't begun any treatment for MS. How does this affect my prognosis? Also, any correlation between these two diagnoses?
So the the short and the long of it is you need to be on a disease modifying therapy. And if your insurance is denying it, then you need your practitioner to fight the insurance. They need to write appeal letters. They need to do peer-to-peers. They need to explain why you need to start on therapy. Now, it's possible that your insurance company is playing a game where they want you to be on a drug A before they'll allow drug B. And so it's possible that they're going to say, look, we're not going to pay for Ocrevus until you've been on something else. But you need to be on a something. Those two diagnoses, it's a little bit outside the purview of talking about MS today, but they're not related.
Thank you. Is there a reason for a male MS patient to look into his testosterone level or no?
Yes, 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 yes. So low levels of testosterone in men with MS make the disease get worse faster, increase progression. They increase cog fog, and they can make fatigue worse, not to mention bedroom problems. And so at the Boster Center for MS, where I practice neurology, we check gentlemen with MS twice a year for their morning testosterone levels. And if those levels are low, we get them supplemented because it helps with symptoms and it helps slow down their MS.
Thank you. Are there any side effects to taking magnesium?
Diarrhea is a very common side effect if you take too much. There's other things that we look out for, but the biggest one is loose stools.
Thank you. What's the correlation between JC virus and MS?
So the JC virus, which is the John Cunningham virus, is a really cruddy little virus. It's not a very effective virus, and it affects half of all people over the age of 30. So it's very common. Like I probably have it, right? And if your immune system is not suppressed, your immune system just beats it up all day long. It's not a very good virus and it can't really hurt you. Under very certain circumstances, when you're treated with certain medicines, typically chemotherapy medicines or Tysabri, then you can have a weird situation where the JC virus can become activated in the brain and it can hurt you. It can cause a scary infection called PML. So the JC virus and MS have nothing to do with each other. They're two separate things. MS is a demyelinating autoimmune disease, and the JC virus is a virus that can cause PML. But sometimes the medicines that we take for MS can increase the risk of PML. And that's why you hear people talk about it.
Thank you. Maya says that they're 62 years old, was diagnosed with tumefactive MS on 9/24. No meds yet, but it's going to start on 12/12. How does TMS rather present differently than regular MS? Any suggestions in managing MS?
So tumefactive is a Scrabble word or a doctor word, which means on the MRI, the MS lesion looks like a tumor. It's not a tumor, but it looks like a tumor. That's what tumefactive means. Interestingly, tumefactive lesions have a better long-term prognosis than smaller lesions. That's what the data shows. So when someone has a tumefactive lesion, we give them the same treatment that we give somebody else with steroids or plasma exchange and things like that, and they get better. And it doesn't really factor into my decision making about starting a DMT. I'm delighted to hear that you're starting a DMT. I also think if you have tumefactive MS and there's a little bit of anxiety surrounding what it looks like, repeating a scan 3 months after you start the DMT is probably the best part of valor to make sure that we're very comfortable with the way it looks afterwards.
Thank you. I'm scheduled for second treatment of Mavenclad in January 2025. On December 2nd, 2024, my labs reflected a value of 740 of lymphocytes absolute count. What is the minimum value to obtain Mavenclad? Is there anything I can do to increase this value?
800, and you just have to wait longer.
Okay. Let's see. What medication over the counter pain reliever works well for most MS nerve pain or musculoskeletal pain?
So two separate things. Musculoskeletal pain is ouchie yaya of the muscle or the joint or the tendon. And so things like Tylenol and ibuprofen and Aleve and some of those non-steroidal anti-inflammatories, aspartame cream, that kind of stuff can help musculoskeletal. For MS pain, there's a lot of different kinds of MS pain. I mean, probably like 8 or 9. I'm going to assume that you're talking about neuropathic pain, where your arm feels like it's burning even though it's not on fire. Okay. And for those medicines, we use what we call membrane stabilizers. Most of those drugs were invented either to treat seizures or depression, and they have a secondary benefit to treat pain. And these are things like Neurontin gabapentin, or Lyrica pregabalin, or topiramate Topamax. There's a whole bunch of them. And these medicines can be very effective for treating MS neuropathic pain, but they're not over the counter.
Thank you. How do you know when you switch to secondary progressive from relapse remitting?
You don't. We used to talk about it like there was a line in the sand, like you've got a second relapsing remitting MS, and then whack, now you have secondary progressive, and that's complete BS. That's not the way the disease presents. Anyone that has a relapsing form of MS is at risk of relapses and at risk of having progression independent from relapses. That likelihood changes over time. So earlier chronologic age, you're more likely to have attacks and less likely to have progression. And later in life, at a later chronologic age, it's flipped, where you're less likely to have attacks and more likely to have progression. But there's no line in the sand. There are some definitions which have been developed. Things like, I haven't had an attack in 5 years, and my disease is getting worse independent from attack, and it's impacting my leg strength. There's some things like that, but it's actually very fuzzy. I don't like those terms because I don't think they add or contribute very much to the way that we treat MS.
Thank you. What are your favorite de-escalation DMTs?
Mavenclad and a bajio.
Thank you. Cannabis gummies seem to make my iherm I,
Lermeets,
ihermitis
my Lermeets.
lime. Say it again.
Lermeet, it's a dead French guy. Lermeet. It's named after a dead French guy. So, um,
Oh, well, this person says they become almost non-existent. Have you ever heard of this?
yes, many times. So first of all, when you have a lesion in your spinal cord and then you bend your neck down, you're stretching the spinal cord. So pretend this is my spinal cord and you bend your neck down, you're putting tension on it. Okay. And if there's a lesion there, it can cause it to fire in a phaptic discharge and you feel like you're being electrocuted. So you bend your neck down and you have electricity running down your back and your feet, like you're zapping yourself. And there's a dead French neurologist named Dr. Lermite, and he named that after himself because back in the day, neurologists did that for some reason. And it's very uncomfortable. And there's lots of different ways to treat it. And I have many patients where they use cannabis to treat that pain, and it's very effective.
Thank you. George from Facebook is saying that he wants to know, what about optic neuritis? That's never really, it's never kicks. He said it never kicks, which means I guess it never goes away. Is it back in?
So I have to make some assumptions, George, in order to answer your question. My assumption is you had an optic neuritis of, let's say, one of your eyes, and you lost vision and it never fully came back. And I would submit to you that 6 to 12 months after the onset of the optic neuritis, the vision loss that you've obtained is probably where it's going to shake out. There's tests that you can do to try to help characterize that. And so there's tests like ocular coherence tomography or OCT, which can measure the thickness in the back of the eye, and it can kind of give you some insights to if things are progressing or not. And if your neurologist is having trouble with it, there's these neuro-ophthalmologists that are these brilliant eye doctors that specialize in the optic nerves, and they may be able to help you.
Thank you. I was diagnosed in June with MS at age 57. I was prescribed baclofen. I think
That's
we discussed this
actually
one
that's
too.
a generic of Tecfidera in different countries. That drug.
Good drug to start.
Eh, it's a mid-range drug. So I think there are drugs that are more effective, but that drug is generally well tolerated. It's not my first choice, which does not mean that your neurologist did a bad job, but I think that there are other things that are more potent that I tend to prefer, which is just my style. That doesn't make me right. It just makes me opinionated.
Hey, do you have a preference as to what type of magnesium is best for spasticity?
I tend to use magnesium oxide, but most of them work. So magnesium oxide, magnesium citrate, those are ones that I probably reach for the most frequently.
And do you have a an opinion on which one is best, Briumvi compared to Ocrevus or Kesimpta?
So I answered that question earlier. I think they're more similar than dissimilar. Kind of, I mean, it was someone else asked a similar question. So it's kind of like saying, like, do you prefer Ferrari or Lamborghini? So you may have an opinion that you like Ferrari better and your neighbor likes Lamborghini better, but they're both really, really fast cars. And so I think if you're having a nerd fight over Ocrevus, Briumvi, or Kesimpta, you're in a good spot because those are all highly effective B cell depleters.
Thank you. Stacy said that gabapentin put 10 pounds of edema on her, especially her legs, after 7 pills over a week, 100 milligrams each. So,
So I think it's very unlikely that baclofen was prescribed. There is no such thing as a 100 milligram pill. But I'm very sorry to hear that you had swelling in your legs, and it's my hope that if that was stopped, it got better.
I just started Ocrevus. How long should one wait to change medication if we don't see any changes?
So again, if you're on birth control, having sex and not getting pregnant, gee, it must be working, right? So the assessment of if a disease-modifying therapy is working is really the absence of bad things happening. So I think that really we have to move forward prospectively. And if you're not having attacks, if your MRIs are not showing new spots, if your exam is not getting worse, if your brain volumes are not shrinking fast, then there's a high likelihood that it's helping you.
Ron said that he was offered today to give, I was offered today to give an Ocrevus shot as opposed to an infusion. I told the rep who called me today to see if I was interested. I told the individual who called me today, no. In your opinion, good choice or no? So,
I would be very upset if a company representative called me as a patient and asked me about switching something. So I sincerely hope that's not what happened. And if that is what happened, then I think that there's a major problem with the behavior of that manufacturer. So that's my first comment, because that is a sacrosanct decision which is supposed to be made between the neurologist and the patient. That stated, Ocrevus now has become available subcutaneously, which is a way of giving it under the skin. And it's been given for many, many years, of course, intravenously. And so having options is always good. And if you're on Ocrevus and you're getting an infusion, you know, we give Ocrevus at the Boster Center for MS over 2.5 hours. It's not that long. And the sub-Q injection from stem to stern is probably going to be about an hour. So, you know, do you think you can get a lot more done in an extra hour and a half? I'm not so sure. And for at least my patients that are on Ocrevus, on IV formulation of Ocrevus, we're not rushing to switch them.
How often are follow-up brain MRIs really needed if someone on Kesimpta is doing well with no new symptoms?
So that's when you want an MRI. So you don't need an MRI if you're doing bad clinically because you're doing bad clinically. We need an MRI when you're doing good clinically because we want to look quote unquote under the hood to make sure we're not missing asymptomatic lesions. So if your car is running perfectly well, you're supposed to take it to the mechanic once a year or so to get a checkup. And the mechanic will look under the hood of the car and say, hey, your oil's low, I need to replace it. And you may say, well, gosh, I didn't notice anything. And the mechanic will say, well, yeah, I'm going to replace it so your engine doesn't freeze up while driving down the freeway. And so, in a similar fashion, we want an MRI when we think things are going well. And I think the better part of Valor is to do that about once a year.
Thank you. And we have a couple questions about the JC virus, which you already discussed. I just want to make sure that these aren't additional
No, they're not.
concerns. Okay, good. Let's see. Let's see. What type of oh, we already people are actually posting in both places, which is getting a little wonky, trying to figure out which one is done. I am 72 and was diagnosed a year ago. I have been on Ocrevus 2 rounds to date, but my doctor is pushing me to change to a bajio due to recent studies showing that Ocrevus not working well over the age of 65. Okay.
That's hogwash.
Okay. I like that word. Well, this will be our last question because we're at the end of the time. Which DMT is best for preserving brain volume? I'm 62 and concerned with this.
There's a lot of the high efficacy medicines that have been shown to help with brain volume. As I mentioned earlier, I think the very best data is with Limtrada, alemtuzumab, which does not mean that's a drug that is right for you. I'm just saying that's where I think the best data is. I'm really enamored with some of the B cell data. So, for example, I think Ocrevus did a really good job of demonstrating that it can help prevent brain volume loss. So, those are two drugs that I'm very impressed with.
Thank you. So that brings us to the end of our time, and we have so many questions left, and I'm so sorry that we didn't get to all of them, but it's virtually impossible unless we are here for 3 hours. So, we are going to be back in another month, and every other month you come, and next month Dr. Thrower will be here on the month that Dr. Boster isn't doing his Q&A, he will. So I thank you all for coming. Our next teleconference will be tomorrow, December 10th at 4:30 p.m. Eastern. It's going to be Dr. Thrower doing his annual once a year MS Trivia holiday style. It's a lot of fun for all of you that want to come. I don't know, Dr. Boster, did you ever join us for that?
I've seen it before. Anyone who doesn't know Dr. Ben Thrower, you're missing something because the guy's amazing. He's a wonderful human. He's hilarious and he's super smart. So definitely tune in because he's a great guy and you'll learn a tremendous amount. And he sometimes dresses up like a pirate.
Yes. And actually, he talks very highly of you, so it's like a mutual thing.
Well,
But
I'll have to send him $20 for saying the nice things.
okay, good. As you leave the conference today, everyone, you're going to see a survey that appears on your screen. Please take a moment and do it. It's only a couple seconds, but it's going to give us an opportunity to understand what's important to you, what's meaningful to you, and those are the type of programs that we want to bring to you. So our sincere thanks to all of our attendees of Facebook and live here. And Dr. Boster, of course, for doing this every other month, and we absolutely love it. I didn't read half of the amount of comments that people write telling us how much they love it. So
Well, I'm honored, and as always, this is an amazing organization, and you're really bringing a wonderful opportunity to this online community. So thank you to you guys,